Hello class, I'm just going to do a lecture here on peripheral vascular disease, okay, which is a very important component of the cardiovascular system. When we talk about peripheral vascular disease, we're really talking about disorders that actually change the blood flow through the arteries and the veins of the peripheral circulation. And of course the outcome with anything that affects that flow will unfortunately cause a decrease in perfusion to many of the body tissues. And we see very often the legs most affected, especially in your big arteries in the legs, but it also can involve patients that have venous problems, venous circulatory problems, and sometimes our patients may have both, all right? So when we talk about peripheral vascular disease, we are really referring to the result of systemic atherosclerosis. And again, it occurs just like it does in the coronary arteries, and again can happen in the peripheral vessels as well, okay? Excuse me. When we talk about PAD, or peripheral artery disease, it can affect the aorta, iliac arteries, the femoral, the popliteal, the tibial, and the peroneal arteries, okay? And with arterial disease, we're going to look at the different manifestations that can definitely happen, okay, with that particular area that's affected. And this is just showing kind of a crude drawing of lower extremity arterial disease, and you can see we have the abdominal aorta there with the common iliac artery, and then you can just see how huge these arteries are, okay? And we kind of make reference to anything that's distal to that inguinal ligament artery, and you can see that many of our patients may have vascular problems that do affect this big artery going down the leg, and of course that will be definitely manifested by changes in color, warmth, hair, and definitely the assessment of peripheral pulses, okay? And this is a very common problem that we see. Peripheral vascular disease is a type of cardiovascular disease, and we see about 81 million people in the United States have one or more types of cardiovascular disease, and this again is one of them, okay? And with peripheral artery disease, we see a lot of associated symptoms that we see obviously when our patients acquire coronary disease. There might be unstable and stable plaque due to the buildup of this atherosclerosis. It's a chronic disease, has been affected by a person's lifestyle regarding diet, exercise, smoking. Maybe they've had very low HDLs, that good cholesterol, and had very high LDLs. Maybe their triglyceride levels have been increased, they're diabetic, they're obese, they're sedentary, they smoke, and they have a lot of stress in their life. So those are, again, those very, very infamous components that we see very much related to patients that have peripheral vascular disease. We look at peripheral vascular disease is either an inflow or an outflow type of problem according to the arteries involved and their relationship to that inguinal ligament that I pointed out. The inflow is distal end of the aorta and the common internal and external iliac arteries above the inguinal ligament, and people start to manifest pain in the back, lower back, buttocks, and thighs when they have peripheral artery disease that involves that area. Outflow has to do with your femoral, your popliteal, and your tibial arteries that are below the other artery, and they really manifest burning, cramping in the calves, in the ankles, in the feet, in the legs, okay? Yeah, that outflow has to do with problems that are below that superficial femoral artery. Sorry, I couldn't think of that word. And again, all those risk factors that I've talked about, advancing age, diabetes, smoking, people, about 10 to 12 million people actually have peripheral artery disease, and many of these people are over the age of 65. And this can be diagnosed by the ankle brachial index that I talked about earlier when we talked about the assessment section of cardiovascular disease. Okay, I don't expect you to know, but just know that some of the key features with chronic peripheral artery disease, we can actually stage that disease where someone has the disease present but really essentially is asymptomatic. Stage 2 could be claudication, and I'll explain what claudication is. Stage 3 is resting pain. And the last one is stage 4, which is very serious. We're talking about now rarely any type of blood supply getting to those extremities, causing necrosis and gangrene to occur. And there's other associated symptoms. I don't want you to memorize those because memorization is not a good way to learn, but I just want you to be aware that we can definitely classify these different stages of peripheral artery disease. And again, when we talk about PAD, the word intermittent claudication, it's a term derived from a word meaning to limp. And what happens with the person is they usually can walk only a certain distance before a cramping or their muscle starts to burn. And then this pain or discomfort really forces the person to actually stop. And once the person does stop, the pain stops at rest. And then when the patient resumes walking, they can walk the same distance before it actually returns. Thus, the pain is considered reproducible, okay? And so as this peripheral artery disease starts to progress, they can walk only shorter and shorter distances before this pain occurs. Ultimately, when it gets to be very severe, when it gets to be end stage, these patients may have pain actually at rest. So this is, again, evidence of the progression of atherosclerosis. And when we talk about it, think about what that word actually means. When we talk about atherosclerosis, it's that thickening, that hardening of the arterial wall that really does become associated with aging. And with this process, we have also a hardening and the formation of plaque. So, and anything that kind of occludes or obstructs blood flow is going to definitely deprive the distal portion of whatever it's providing blood to, depriving them of oxygen and the really necessary nutrients needed for that extremity to perform well, grow hair, have good color, and to be a healthy extremity. Okay, so that's basically what we mean by this particular slide and what we mean by intermittent claudication. And this slide really shows typical clinical manifestations of somebody who has arterial disease. The skin becomes very thin, shiny, and taut. They lose a lot of hair on the lower legs. They have diminished or absent pedal, popliteal, or femoral pulses. If they raise their legs, say for instance they're going to rest in like on a step stool, that extremity will be very pale, which means you'll see it turn kind of a whitish in color. Because the blood is kind of coming from the lower extremity back up to the heart. They also have reactive hyperemia of the foot with dependent position, which means that when they're sitting down and the feet are dependent, resting on the floor, they will get very red with that type of positioning, okay? It's really important that we really continue to, assess pulses, especially like the post-tibial. It's one of the most sensitive and specific indicators of arterial function. And also you're going to see that with severe arterial disease, the extremity is going to be very cold to touch. Sometimes we can also see a little bit of cyanosis or darkening in the area. And as I said, pallor or whiteness may occur when the extremity is elevated, and they'll get dependent rubor. And that's kind of a fancy name for like the extremity becoming very red when the extremity is lowered. And also, because of decreased oxygen and nutrients to that area in the muscles themselves, you will see over time a patient will develop muscle atrophy from prolonged chronic arterial disease. And really what you want to do too is when you're assessing the pulses in the feet, you really want to kind of compare and contrast how does that pulse feel in the left leg versus the right leg. Really, check to sometimes as these areas are deprived of oxygen and nutrients, patients begin to develop arterial ulcers. They're very painful. They start basically on the toes, especially the big toe, the great toe, sometimes between the toe and up on the upper aspect of the toe. And over time, because that area is not getting enough oxygen, the toes can become gangrenous or necrotic. And that is where, a decision needs to be made as to whether or not that particular extremity, the toe itself, needs to be amputated. Okay? So this is also what we see occurs in the forefront of toes, aggravated by limb elevation, occurs from insufficient blood flow, occurs more often at night. That's the pain at rest. That's that rest pain that we were talking about. This is a great slide because it really does compare what happens in leg ulcers if it involves the arteries versus the veins. And this makes sense. Think about arterial circulation. That's what your peripheral pulses are. So they may either be decreased or absolutely absent. Capillary refill may be delayed, may be beyond 3 seconds. Edema is absent. Loss of hair on the legs and the feet. Rounded shape. You see the ulcers more on the toes, the foot, or the lateral malleolus. Becomes very black and eschar, granulated. Sorry, I flipped this slide too early. And then let me get it down more into viewing. Pain at rest, ulcer pain or not. You can see how this differentiates between venous. They will have pulses because this is not arterial circulation. It is capillary refill. And think about people that have like varicosities. They'll have a lot of edema in their lower extremities. Hair will still be present. They can also have venous ulcers that are more near the medial malleolus, regular shaped. They can even actually have drainage, ready granulation. And, with people that stand all the time in their professions, jobs, more pain and a dull ache in the calf and the thigh area. And sometimes these ulcers can actually be painful. There's a nice chart in your book on page 721 where there's a chart 36-4 that really kind of differentiates between arterial ulcers, venous ulcers, and even diabetic ulcers. Okay. On page 720, please look at the picture in figure 36-4. It shows you that red ruddy color, and you can see how the foot is just red in color. It's that dark red, which is not normal. And they have what we call dependent rubor in the left leg of a patient with peripheral arterial disease. As far as diagnostic studies, patients can have MRAs, which are magnetic resonance angiographies. It really is used to assess blood flow in the peripheral arteries, and they use a contrast medium such as gadolinium to help visualize that blood flow through the peripheral arteries. And this is the one that is often used to diagnose PAD, although sometimes they can use a CTA, can be performed. Other times they use a Doppler probe, and they can also take actually blood pressure readings on that leg. And they really, the book talks about differences in pressures with inflow disease versus outflow disease. And I earlier mentioned in the assessment of the cardiovascular system about ABIs, which stands for ankle brachial index. And what they do is with outflow disease, it compares ankle pressure with the brachial pressure, and they look at the ratio between the two. And this value can be derived by dividing the ankle blood pressure by the brachial blood pressure. And so an ABI of less than 0.9 in either leg is diagnostic of PAD. And many times if you have a diabetic, and that's why another reason it's so important to know your patient's history and other comorbidities, patients with diabetes are known to have a falsely elevated ABI. So that's very important to know. And there's other kinds of testing that, read about the Doppler-derived maximal systolic acceleration, which to me is something I've really not heard of. And then, of course, they do exercise tolerance by actually providing a chemical stress test or actually having the patient walk on the treadmill. So that is just kind of the pathology behind peripheral artery disease, and really comparing the leg ulcers that occur due to the fact, just kind of like a pressure ulcer, due from ischemia, and it's the same principle behind arterial and venous and diabetic ulcers too, where it really is impairing vascular blood flow. And again, this is more comparisons made on the differences. And please know this and look at each of these manifestations and say to yourself, why is that happening? Because thinking about it in regards to, this is the arterial side, this is the venous side. You may have known someone that has varicosities. What kind of symptoms do those people see? I know these are some of the complications that we have just talked about. Atrophy of the skin, it makes sense. It's not getting a good blood supply, and of course the muscles are definitely going to be affected. Those will also atrophy. Delayed wound healing, wound infection, especially when tissue necrosis sets in, and of course arterial ulcers, which later could eventually lead to amputation. And this is exactly what I just said. Amputation if blood flow is not adequately restored or if severe infection occurs. Because with this infections, patients can develop, obviously, the serious problem of sepsis. And again, I've just talked over some of the diagnostic studies, Doppler, ankle brachial index. Please understand that one. That's probably one of the common ones that they actually do in a lot of the physicians' offices. Angiography would make sense, because just like we did an angiography of the coronaries, they can do an angiography of determining the blood flow in the peripheral arteries as well. And of course the magnetic resonance angiography, the MRA. And of course we know that, just keep in mind that, as the nurse, what's my role in preparing these patients for these particular diagnostic studies? And anytime we're invading an arterial vessel, or even a vein as far as that is concerned, we want to definitely assess that patient post-procedure to make sure there's no problem with hemorrhage, embolus, or any more or further impairment of blood flow to that extremity. Because we want the diagnostic test to be helpful in determining what is the cause and how much atherosclerosis is actually there. So, that's the kind of thing that we want to do. And, many times when they do exercise tolerance testing, they'll do like a plethysmography, which kind of shows you like a graph as to where there is an impedance of blood flow to that particular arterial area, and you'll see a decrease in those waveforms. So that's another indication that arterial disease actually exists. A lot of the management of patients depending on the severity of their atherosclerosis in their peripheral arteries really is, again, assessing to what degree they do have peripheral vascular disease, risk factor modification, smoking cessation, including use of nicotine products. I mean, smoking is an absolute must to kind of refrain from. That further vasoconstriction obviously is not going to help your patients, you know, with any type of providing blood supply to that area, okay? And I guess it's important, too, to determine if the impairment of blood flow to that extremity is due to arterial disease. Is it venous disease, or does the patient have both? And that's the first diagnostic study that, or the first diagnosis that we need to make. And if they have, you know, really high LDLs and low HDLs and high triglycerides and cholesterol, we really need to get them on some kind of statin to bring down those levels to further prevent the progression of atherosclerosis. Blood pressure is essential to maintain, and if they're diabetics, we want to keep that hemoglobin A1C below 7.0% for our diabetics, because obviously they're more at risk for cardiovascular disease. And, you know, in the beginning, if we do see that they have maybe mild atherosclerosis, it's really important that we encourage our patients to exercise, because with exercise, it will definitely improve arterial flow, as well as hoping to build collateral circulation in those areas. And that provides blood to the affected areas through the development of very smaller vessels, not as good as the original ones, but it can definitely compensate for the vessels, the large vessels that have been occluded, that we can get some kind of circulation going through those areas that are definitely deprived because of the big vessels that are occluded. But obviously that needs to be assessed as to what degree of exercise these patients should become involved in, because you know, they might have intermittent claudication or might also have a history of coronary disease. So we have to be very concerned about what is the best exercise plan for these patients who do have the beginning of peripheral vascular disease. You know, and your book does talk about positioning. Positioning is essential to promote circulation. We know some patients who do have arterial disease or even venous disease do have some swelling in their extremities, and we really want to teach them to avoid raising their legs above the heart level, because this kind of positioning really does slow arterial blood flow to the feet. And many times these patients who have severe peripheral artery disease, they actually sleep with their legs hanging from the bed or sitting upright in a chair for comfort. So it's very important that we provide that dependent positioning so that that blood can get down in those lower extremities and provide as much circulation as possible. And, you know, really instructing them about avoiding crossing their legs, wearing restrictive clothing, things like that. Anything that interferes with blood flow is really important to teach them to not do anymore. Even just temperatures can affect the dilatory manifestation of that particular vessel. Keeping the patient in a warm environment, wearing socks, wearing insulated shoes, really to avoid applying direct heat to the limb, like with a heating pad or hot water, because as time goes on, they really lose a little sensitivity to the affected limb, and the person can actually burn themselves. Okay. And really staying away from things that that involve cold temperatures, because we know cold temperatures really do cause vasoconstriction. And really encourage them to drink adequate fluids to prevent increased blood viscosity, and really to avoid, a lot of stress, caffeine and nicotine, especially smoking, that really will prevent vasoconstriction. The book does talk about that the vasoconstrictive effects of each cigarette may last up to 1 hour after one cigarette is smoked. So that's really relevant, that area may be deprived of oxygen and blood after a person smokes a cigarette. Okay, so let's talk about medications, because again, a huge part of the patient's treatment of peripheral vascular disease, and so let's go over some of these. Antiplatelet agents. We know the importance of aspirin. Many times your patients might be on aspirin, and even Plavix or clopidogrel is two such examples of antiplatelet agents. Okay, they really say Plavix is even better for reducing the risk of myocardial infarction, ischemic stroke, and even vascular death. And sometimes patients may be on both. And why do we give these medications? Just for the same reasons we give them for our patients who have known coronary disease. We're always concerned about that abrupt plaque rupture that could cause the platelets to go to the site and totally occlude that vessel. Okay. Another drug too, I think we'll get to that, is, these are ACE inhibitors, ramipril altase. They actually decrease cardiovascular morbidity, decrease mortality, increase peripheral blood flow, and actually improve the ankle brachial index test. And they actually help a patient walk farther without developing any type of intermittent claudication. So that's ACE inhibitors. It has that vasodilatory effect, so that's why it helps our patients with peripheral vascular diseases. Now, this is another drug classification, Trental or penoxazoline, and what this actually does is a hemorrhagic agent that increases the flexibility of red blood cells. It decreases blood viscosity by inhibiting platelet aggregation and decreasing fibrinogen, and thus increases blood flow in the extremities. So that's how it works, along with cilostazol, Platol, increases vasodilatation, and again increases walking distance. Okay. And of course, I talked about the importance of exercise. It improves oxygen extraction in the legs and skeletal metabolism. Walking is the most effective exercise for individuals with claudication, and about 30 to 60 minutes daily. And that is what we would recommend, and we can have our patients work up to that. Okay. And of course, talking about keeping their weight under control, dietary cholesterol, decreasing intake of saturated fats, and decreasing their sodium. Those all are just risk factors for the development of atherosclerosis. And these are some of the interventional radiological procedures that you may see occur. Okay. Intermittent claudication symptoms become incapacitating, pain at rest, ulcerations or gangrene severe enough to threaten viability of the limb, which it really provides a compromise to that limb where maybe toes or feet or maybe the whole extremity needs to be amputated. These are some of the invasive non-surgical procedures. This is a way in which we see blood flow improved by PTCA, kind of the same principle behind what we do in the coronaries, we can do in the big vessels in the legs. we actually dilate those vessels with a balloon catheter, and you know, we can actually see an improvement of blood flow through those extremities, and you know, it's important too that they have to be a good candidate for this procedure, that that the occlusions need to be accessible by a catheter, and sometimes these can last up to, you know, 3 to 5 years, and sometimes these patients do eventually develop reocclusion of the vessels. You know, they can put, you know, stents in and things like that to hopefully keep the vessel open and improve vessel circulation. And another arterial technique is an atherectomy, where they use like a rotoblader, and it just kind of scrapes the atherosclerosis from inside the artery while trying to prevent minimal damage to that artery, okay? Because if you know, actually scrape too much off and actually cause a tear in that intimal wall of the artery, you could kind of simulate an injury, which would bring platelets to the scene unless they were on some kind of antiplatelet medication, okay? So these are some of the ways in which we can hopefully alleviate and decrease some of that atherosclerosis that's taking place. And one of the most common surgical approach, now these are surgical management of patients that might have severe and very symptomatic arterial diseases and arterial revascularization, which we can classify as either inflow or outflow. And again, what they might do is do a graft. They might do a patient's own saphenous vein graft, or, you know, it just depends on, you know, if it's an inflow or an outflow problem, okay? But obviously, whatever bypass operation is necessary, this is a very serious situation. These patients are usually in ICU overnight to assess vascular flow, check vital signs, make sure there's no complications with bleeding, or that there's been some collapse of that bypass area. They'll be in ICU with possibly hemodynamic monitoring, so we can really evaluate these patients. And of course, just the very typical complications that someone may acquire going through any type of a surgical procedure with respiratory issues and, you know, DVTs and all things like that. You know, those are the same principles behind any type of surgical procedure. So that's pretty much, you know, what our role is when these patients have this type of surgery. And a lot of times when it's done on an elective basis, many times I know, as I was a critical care nurse, say the patients were going to have the surgery on a Monday, they would be admitted on the Sunday before, and we would go to the floors and talk to the patients and even bring them to the critical care unit to kind of give them a tour along with their families, to kind of teach them about where they're going to be for the next 24 or 48 hours, and kind of do some teaching while they're alert, oriented cognitively, you know, with it, so that, you know, when they wake up in the critical care unit, they're not like totally stressed out because they're not really familiar with their surroundings. So that's what, you know, we used to like to do with our patients, to give them a sense of reduce and alleviate some of their anxiety. All right. So that's so much for our patients with surgical procedures. And again, this is a slide that kind of showed you where the disease is. You can see where this yellow part is, where this patient has all this arterial disease. And what they'll do is they'll graft that whole area and see how it bypasses that occlusion or that disease, so that we can promote and provide a better arterial flow down to those lower extremities. So that's what they'll actually do in surgery. And these are some of the things they might do. And you don't want to also rule out any type of arterial disease in the carotids because that might impair blood flow to the brain. So a lot of these patients might have an endarterectomy, or they can actually have a patch graft angioplasty, or they can actually cut out the diseased area and put like a graft there. We used to get these endarterectomies into critical care units also, because let's face it, we want to keep a good blood flow to the brain, otherwise these patients can have ischemic strokes, and we are assessing their neural function, as well as, making sure that patients don't have any deficits and that there's no chance of hemorrhage or bleeding or, infection. So these are some other incidental vascular diseases that we might see with our patients. The first one here is Buerger's disease, and there's the long name, thromboangiitis obliterans. It's a relatively uncommon occlusive disease limited to the medium and small arteries and veins. It's basically a disease that presents with claudication in the feet and lower extremities, gets worse at night, causes by ischemia and fibrosis of the vessels and extremities with increased sensitivity to cold. Okay. As you can see, very much identified with people who smoke. Less commonly, veins are involved, and it can also be an autoimmune or more of a hereditary disease. Extends into the tissues around the vessels, resulting in fibrosis and scarring. Okay. That's what we mean by Buerger's disease. So the important thing with this problem is that we really get the patients to quit smoking and to avoid the cold, and if they have to go out in the cold, to make sure that they wear gloves and warm clothes, and to avoid a lot of caffeine and to manage their stress pretty good. Okay. And really, if they're taking nifedipine, to avoid grapefruit and grapefruit juice, to prevent severe adverse reactions with the medications. And really, how we want to treat these is with vasodilatating medications, and so we just look at the common complications that can arise from those meds, such as facial flushing, hypotension, and definitely problems with headaches. Your book talks about the P's of ischemia, symptoms, P's of ischemia: pain, pallor, pulselessness, paresthesia, and what's the last one? Poikilothymia, which is coolness to touch. So you want to think about, does my patients have those particular P's of ischemia? Okay. And this is what somebody with Buerger's disease would have. Do you see how those vasoconstriction really causes necrosis to especially those lower extremities? Looks like this person on the right, look how the toe is also very edematous, and this patient is probably going to eventually lose that toe because now we've got necrosis, and sometimes these get very infected, and these toes really begin to smell very bad because of the infection and the odor that's taking place. These toes really need to be cut off. All right, Raynaud's syndrome. Raynaud's syndrome is painful vasospasms of the arteries and the arterioles and extremities, especially in the fingers. And what happens is the patients may have sudden vasoconstriction, resulting in color changes. Fingers may start to get numb, tingle, and have burning pain. And cold is one big trigger that kind of gets this going and occurs more frequently in women. And this can also be evidenced in even the fingers, I mean in the toes and the feet themselves. I had somebody I knew that ended up with Raynaud's, and not only did she have problems with her fingers, but she also had the same problems in her feet and her toes. She was a smoker but has quit smoking, and she's on medication, and she really does much better now. But yeah, that's where you have intermittent arterial vaso-occlusion, kind of a spasm of those arteries, okay? And again, you know, giving medications that are going to, you know, vasodilate the vessel. Sometimes calcium channel blockers are good ones to kind of vasodilate those vessels. And that's kind of how they look. Do you see on the left how these fingers are all white? Those are the vasoconstriction of the arterioles taking place. And you can see the front side of the hands and how you get that white color manifesting with a patient that has the Raynaud's syndrome. Okay. Okay. Venous thromboembolism. Now we're going to talk about venous problems or venous insufficiency. It could be due to a clot, could be a thrombophlebitis, an irritation or inflammation of the vein, a DVT, pulmonary embolism, or Virchow's triad, which has to do with blood flow, endothelial injury, and hypercoagulability. And then, of course, phlebitis. That's why it's really important that we as nurses are assessing our peripheral IVs to make sure that our patients are not developing phlebitis. We see it very common in patients who have IB or HEPLOCs, and this can really predispose our patients to developing thrombosis. Okay. Remember, a thrombus, also called a thrombosis, is a blood clot believed to result from an endothelial injury, venous stasis, or even hypercoagulability. It can be attained to one or all of those situations that can occur, and it really is associated with some type of inflammatory process. And then once that clot occurs, there is an inflammatory process that occurs around that clot. And what happens is now you have a thickening of the venous wall, and subsequently possible leading to embolization in the form of an embolus, okay? And this is where you might want to kind of conclude that the patient is at risk for developing a pulmonary embolus. And that's one of the most common types of embolus, and we've kind of somewhat talked about that earlier with a respiratory lecture. And of course, thrombophlebitis is a inflammation, and then we have a pleurophrombosis is a thrombus without inflammation, okay? And then we talked already about DVTs. It's one of the most common types of thrombus. It's more of a deep vein thrombosis, and it's much more serious than superficial thrombophlebitis because it represents someone being at more risk for developing a PE. Okay, and then I've already talked about Virchow's triad, so please know that. It makes a great select all question. Stasis of blood flow, endothelial injury, and or hypercoagulability. Okay, so just wanted you to know about that. Again, how we assess and look at venous problems is calf or groin tenderness or pain, sudden onset of a unilateral swelling of the leg. Hohmann's sign used to be like true indication of venous problems, or maybe like a clot in the calf, a DVT, but really that we have seen along the way that it has proved to be not so diagnostic of somebody developing a DVT. Localized edema, venous flow studies, and venous duplex ultrasonography. Even in MRI, and patients that have high D-dimers are much more prone to venous disease. And remember, think about how the veins work. It must be patent, that particular vein, with competent valves to function properly. Remember, veins pump blood toward the heart, so if one or more of the veins aren't operating efficiently, they become distending, leading to other problems, okay? And two main problems are venous thrombosis, which we talked about, and that can lead to a pulmonary embolus. And the second is venous insufficiency, causing the patient to develop varicose veins related to defective valves. And that is not so life-threatening, but it can be very uncomfortable and can be painful, okay? And remember, we get really concerned about, emboli, because that can also travel to the brain as well as to the heart, and really can, it's less common, but it can account for a lot of the 25% of hospital deaths that we see happening. Some of the predisposing factors, obviously patients undergoing certain surgical procedures. The highest incidence occurs with somebody that's having hip surgery or open prostate surgery, even pregnancy, ulcerative colitis, heart failure, immobility, and even a phlebitis. Anything associated with invasive procedures such as IV therapy. Severe infections, even some of your systemic lupus, erythematosus, and polycythemia vera, any patients that are on oral contraceptives, and even anybody involved in some type of trauma, okay? And remember, patients with DVTs may have symptoms, or they can actually be without symptoms, okay? And these are some of the signs and symptoms. We talked about calf or groin tenderness, sudden onset of unilateral swelling. And as I said before, with Homans, only about 10% of patients have this false positive, so it's not usually advised to go by a Homan side. And again, really assessing their respiratory status. Have they become more short of breath? This could bring evidence that the patient has really developed a pulmonary emboli. Some of the diagnostic studies are contrast venography, which allows about 85% of all DVT clots to be visualized. Duplex ultrasonography, that's probably one of the most common ones. And it's non-invasive, and it's probably the preferred diagnostic test. And then Doppler flow studies, they're more sensitive in detecting proximal rather than distal DVTs. And then this impedance plethysmography, which assesses venous outflow and can detect more than 90% of the DVTs above the popliteal vein. All right. So let's talk about what we're going to do for these patients when we do diagnose that they have a PE, or not a PE, but a possible DVT. Okay. Non-surgical, obviously rest, supportive therapy for DVT has typically included bed rest and elevation of the extremity. And really, they're even looking at some of the evidence that sometimes, even if the patients get up and ambulate, that it's not going to cause that clot to travel and cause the patient to develop a pulmonary emboli. So that's still in question what we really want to do as far as activity. Some healthcare providers prescribe intermittent or continuous warm soaks to the affected area. And to prevent the thrombus from dislodging and becoming an embolus, do not massage the affected area. Okay. So let's talk about, rest, drug therapy, preventive measures. And so some of the drug therapy is anticoagulants, IV unfractionated heparin. And anticoagulants are the drug of choice for actual DVTs and for patients at risk for DVTs. But we have to watch, because with anticoagulants could cause medical complications and even patients dying. So these unfractionated heparins are things like heparin, which you're most familiar with since you had your lab on the week 1. And I'm not going to get into all the ways in which heparin works, and the what's the word I want to use? The antidote when our patients are on heparin, and what kind of teaching we need to do with our patients who are on heparin. Okay, but it's important before they start these. We're going to check PT, INR, CBC before treatment, then titrate heparin as lab values indicate. And then the antidote for heparin is protamine sulfate. I will mention that because that's important that you continuously know that. So then we have to look at too, and we'll discuss this more in details when we get to hematology, but with patients being on a heparin drip, they can develop heparin-induced thrombocytopenia, which can affect platelet count and cause the platelets to decrease significantly, putting your patients at serious risk for bleeding. So we'll get into that later on, okay? But I do want you to be aware that it's important to assess those platelet counts before we get anybody started on any type of heparin. And then, of course, let's see, low molecular weight heparin, and that would be an example of Lovenox, okay? And then we know when our patients start coming off heparin, we're going to put them on some Coumadin. And it works in the liver to inhibit synthesis of vitamin K. And remember, Coumadin takes 3 to 4 days to reach therapeutic levels, so heparin is continued at that time. So we're going to definitely monitor their INR, and we would like that to be between the range of 2 to 3. Okay. Usually they start them at 5 milligrams and then increase as needed depending on what the INR is. And usually they're on Coumadin for about 3 to 6 months after a DVT. And we know the antidote for Coumadin is vitamin K, so we want to keep that on hand. Some of these patients may be on thrombolytic therapy, but we don't use it as often anymore because of the chances of severe bleeding. And of course it's contraindicated in patients who are post-op, pregnant, after childbirth, after trauma, after brain attacks, and after spinal injuries. And some of those drugs may be streptokinase, but like I said, physicians are very skeptical in ordering these because of the fact that really puts your patient at very high risk for bleeding. Okay. Sometimes surgically, patients might need a thrombectomy, which is the most common surgical procedure for removal of a thrombus. And then they may also put in inferior vena cava filtration. And what they do is they actually insert a filter device or an umbrella into the femoral vein. And this is meant to trap emboli in the inferior vena cava before they progress to the lungs. There's actually holes in this device that actually allow the blood to pass through and not really interfere with returning blood to the heart. Okay, and the good thing about these is used to be that they were in permanently, but now the newer ones they actually can take out and put in a new one, so they can be interchangeable. So again, anytime we go through a vein, we want to check for bleeding. They can also do ligation or external clips, and that would be done if the inferior vena cava filter is not successful or actually becomes blocked. So that's another possible surgical procedure. And again, all the important discharge instructors when your patients go home. And I'm not going to get into that because you've had that over and over again about education on anticoagulant therapy. Okay, hopefully you got that in week 1 with your lab. When we talk about varicose veins, all they are is distended protruding veins that appear darkened and tortuous, and they can occur in anyone, but they are more common in adults older than 30 whose occupation really requires somebody that's standing for long periods of time. Somebody that works in surgery, maybe a surgical tech, somebody that works at the grocery store, she's a cashier, she's standing on her feet. Sometimes school teachers, they stand a lot during the day. Sometimes we see that in other comorbidities where people are, have heart disease, they're obese, or even have a family history of varicosities. Both superficial and deep veins can become distended, and as the vein wall weakens and dilates, venous pressure increases and the valves start to become very incompetent. So that's kind of the pathology about it. And really the severity of varicosities really depends on how dilated those veins are. And we've seen the spider veins and dilated intradermal veins, less than 1 to 3 millimeters in diameter. They're actually visible on the skin. You've seen a lot of people that have those. And sometimes, they don't really bother somebody, but they may not be very, very attractive, okay? But then we see more extensive disease where actually people have very bulging edema, where there's a feeling of fullness in the legs. They might itch, and as a result, signs and symptoms of venous insufficiency may occur, okay? And so that's where they might become a situation where they really need to be treatable, okay? And sometimes these really can cause a lot of pain and discomfort. And these are some of the collaborative management, elastic stockings, elevations, sclerotherapy, surgical removal of the veins, and radio frequency energy to heat the veins. And a lot of times too, they'll do, to diagnose varicosities, a actual Trendelenburg test where they lay the patient down with legs elevated as they sit up, and veins normally fill from the distal end, and with varicosities the veins fill from the proximal ends. So going back to some of the treatments, let me go back to here. When we talk about sclerotherapy, that's only done on a small or limited number of varicosities. And what they do is they actually have this particular solution that they inject directly into the vein, or the laser device may be used. And in 14 to 21 days, that sclerosed vein is drained of trapped blood, and a second pressure dressing is applied for 12 to 18 hours. And then another thing that they can do is surgical removal, where they're actually remove veins that are larger than 4 millimeters in diameter. So, sorry about that. I dropped the microphone. All right, and then this last one is phlebitis, inflammation of the superficial veins, caused by an irritant such as IV therapy. And we know that some of the symptoms we see is redness, warm area radiating up an extremity. The patient complains of it causing her a lot of pain, or him a lot of pain, soreness, swelling. And how we treat it is warm, moist soaks and elastic stockings that we might give to the patient, depending on where that particular phlebitis is. We worry about complications of necrosis, infection, or pulmonary embolus. So just watch that. That's why it's really important that we adhere to hospital policy in regards to how long these IVs, these peripheral IVs should be in, to prevent phlebitis from happening. Okay. And this is a DVT, and as you can see, this left leg is much more edematous, the calf. And these are what we call those bulging varicosities that really look very painful when I look at them. And these are the ones that we might see the actual sclerotherapy done, or even surgical removal. And this is what they actually do. Like I said, they do the, I want to get back to this. I hope you see, they actually inject this into the varicosities, and the veins dry out and shrink, and then they slowly disappear as they are gradually absorbed by the body. And look at the difference. I mean, to me, I find that absolutely great. And this is an ablation of a vein, and where they remove them in that way, where they actually do vein stripping. And of course, we worry with DVTs, pulmonary emboli, and we've already somewhat talked about that. But you can see where there's an emboli right here, which could cause this whole area to become infarcted. And you can see where sometimes we see multiple emboli in the small branches of the left pulmonary artery. And this is that umbrella that I talked about, and you can see where they put it right here, okay, in the inferior vena cava. And it's very small, but see the holes that allow blood to flow through it, so that doesn't interfere with the blood flow. And these are just examples of what type of vascular problem, so you can differentiate between those two and what kind of a vascular problem is this. And these are getting really very nasty looking, and you can see how impairment of blood flow can really cause a lot of problems. All right, well, that concludes my lecture on peripheral vascular disease. If you have any questions, please let me know, and I hope you have a great evening. Thank you.